Thank you very much, Dr. Gamalniezi, for the kind introduction. Good afternoon, everyone. First off, I would like to thank Professor Dr. Ahmed Kamel for the kind invitation to this wonderful conference. I will be talking about percutaneous bone stabilization. My main objectives for this talk are to give you an overview of what is percutaneous bone stabilization and to show how percutaneous bone stabilization highlights all we can offer patients as interventional radiologists. I have no disclosures. So this is where I'd like to start most of my talks. The oversimplified cancer patient journey starts with diagnosis, moves on to treatment, and then palliation. Now this is oversimplified because they all intermingle, but we as interventional radiologists can play a part in all these phases. So what is percutaneous bone stabilization? How I like to define it, it is a minimally invasive procedure that aims to consolidate bone and alleviate pain. And I think a good place to start is vertebroplasty and kyphoplasty, which are very common and very well-known procedures that address compression fractures in the vertebral bodies. Vertebroplasty is just a cement injection to consolidate the bone and alleviate the pain, whereas kyphoplasty, you just add insertion of a balloon to expand the vertebral body and restore its height before injecting the cement. So this achieves the two objectives of alleviating pain and consolidating the bone. Now, vertebral body augmentation only relies on cement because it's dealing with compression forces, and so you don't need anything additional to address any other different type of force. Whereas in a fracture such as this, in the right posterior iliac bone, the forces that are acting here are more not just compression forces, they're also torsion forces. And so this requires a different approach. And so this, I think the highlight of the evidence supporting this and where it all started was in France by the team of Frédéric Deschamps, where they talked about their experience with fluoroscopy and cone beam CT guided fixation by internal cemented screws for pathological pelvic fractures. This was a retrospective analysis of 100 consecutive patients who had cancer, who had pathological pelvic fractures that were managed with percutaneous fixation by internal cemented screws. And the whole point was using these screws as anchors for the cement and using the cement as anchors for the screws to address the different types of forces that act on the pelvis. They saw that in these patients, their pain was significantly improved at 6 weeks from 6.1 VAS score to 2.1, and the opioid use was reduced at 6 weeks from 91.3 milligram morphine equivalent dose to 64.6 milligrams. Then they started to expand on this. Now that we know how the forces on the pelvis work, we can expand it to other areas in the body, such as impending femoral neck pathological fractures, such as in patients with metastatic cancer, from the same group in France, where they looked at 61 consecutive patients who had fractures in the femoral neck or impending pathological fractures in the femoral neck, and they aimed to consolidate and prevent these pathological femoral neck fractures. They saw that pain was significantly improved at 1 month after fix from 4.2 to 1.8. That's the main objective of these procedures, is to alleviate the pain and consolidate the bone, as we said. So I think the best way to understand how we do this is to go through a case. This was a 61-year-old female who had metastatic thyroid cancer and had right hip mechanical pain. This was the image that we saw initially, showing the right posterior iliac bone fracture with a lot of loss of bone. However, there is healthy bone on both sides, and you need this to be able to anchor your screws. So the initial placement, we use cone beam CTs mainly for the procedure with planning software to be able to navigate inter-procedure. So you place 2 bone biopsy needles as your introducer needles, confirm in 2 views that you are where you need to be, advance your K-wires in the trajectory that you need. You can use cone beam CTs mid-procedure to confirm that you are in the appropriate trajectory. Once you are across, that's when you select the appropriate length screw. You want the screw head to be anchored to the cortex, and you don't want the screw to be extending on either side of the bone. You advance it over the K-wire, and then once you confirm that it's in a good position, In this case specifically, we saw that there was a need for what we call a locking screw, which goes from posterior posterolateral into the sacrum to interlock the two iliac bone screws. Once that was placed, you place that third screw, and then you insert a fourth cannula where you want to inject the cement. There are several ways to inject the cement. You can either remove your access and then find the tip of the screw and inject the cement through it, or you can use an additional access to inject the cement to where you need to be to further consolidate that bone fracture. And this was our final fluoro loop confirming, showing the positions of the screws and the cement. And this was our cone beam CT post showing appropriate position of the two screws in the iliac bone with cement extending down to the acetabulum and the interlocking screw in the sacrum. Our sagittal view showing appropriate position. This patient had significant pain relief and was able to ambulate after this procedure. We usually keep them off their feet for about 12 hours, and then they work closely with our rehab team to be able to restore their strength and restore their ability to ambulate. Now, if you want to know more about percutaneous bone stabilization, I think this is a good place to start. This is a review article that we wrote in 2022 highlighting image-guided procedures to stabilize the pelvic girdle in cancer patients. Now we're expanding these indications, and this was what we presented at SIR in last year, 2025, still this year, but the end of this year, where we looked at sternal screw fixation and cement augmentation for patients with pathological fractures of the sternum. Now this it's a novel indication, and this requires a lot of discussion with the patient, with the family, with the team to gauge how much the pain is impacting this patient's quality of life. We looked at 8 patients who had symptomatic pathological fractures of the sternum that were not suitable for surgery, did not receive radiation, and we saw that their pain significantly decreased post-procedure by 7 points from 8.4 to 1.4. Now, why do I say that percutaneous bone stabilization is a good point to show that we can help cancer patients throughout their journey? This is a good case. This is a 64-year-old male who had metastatic lung cancer, severe mixed sternal pain, mixed meaning that it's biological as it related to the tumor itself and mechanical related to movement. That was significantly impacting their quality of life. As you can see here in this sagittal PET CT, there's active tumor infiltrating the entire sternum. And in that same setting, a biopsy was needed to address if there's any further treatment options for this patient. So once we got access into the sternum, we were able to get a biopsy, so that fulfills the diagnosis part. And after we got access through the sternum and the lateral view, we were able to perform ablations to treat the tumor in that area. Again, our goal is not to eliminate all the tumor, it's just to palliate enough, to treat enough of it to address the biological component of the pain. Then we used a small kyphoblasty balloon to inflate enough space to allow good cement deposition, placed our K-wire, placed our screw, and injected the cement through it. And this patient had significant relief of pain after this procedure, and he was able to ambulate. He had no more pain during breathing. So thank you very much for your time. Now it's my turn to present Professor Dr. Gamal Niazi, my